Hello, I'm Camilla Carr. Today we're going to talk about clinical trials and health disparities. Welcome to For Your Health. One of the ways that scientists come up with medicines for treating some of our illnesses is by conducting clinical trials. On today's program, we're going to be talking about what a clinical trial is. We're also going to talk about health disparities and if there is a connection. Joining me in our studio audience is our friend Dr. Claudia Baquet, who has been a guest on our program in the past. Dr. Baquet is director of the Center for Health Policy at the University of Maryland School of Medicine and principal investigator at the University of Maryland, Baltimore National Bioethics Research Center. Thank you for joining us.
Thank you for having me.
What is a clinical trial?
A clinical trial is a medical research study that can look at a new way to either prevent, to diagnose, or to treat illness. It can also look at ways to improve the quality of life for individuals with certain diseases.
For example?
For example, for cancer patients. There are a number of clinical trials that have taken place for patients that have breast cancer that look at ways to increase their quality of life and how their ability to function will be on a day-to-day basis.
Now, drug companies, pharmaceutical companies, they use clinical trials, correct?
Yes, and the organization that pays for the clinical trial is called the clinical trial sponsor. There are federal government supported or sponsored clinical trials. There's also industry or pharmaceutical company supported clinical trials. At sometimes, the federal government as well as industry will partner on sponsoring a clinical trial.
What regulations, though, exist to keep a company from skewing the study so that they can get the exact results that they want?
The design, the planning, the analysis, the execution of clinical trials, those that are particularly federally sponsored, are incredibly rigorous. What a person wants from a clinical trial is to be able to trust the result from the medical research study. You cannot trust the result if you have individuals manipulating the results, the analysis, what's happening with the patients. And so there is standardized regulations that are very complex that anyone conducting a clinical trial has to adhere to. And these are often laid out in what's called the protocol or the clinical trial cookbook.
And is that given to the participant?
Often the entire protocol is not. It's given to the people actually conducting the trial, and they're often thousands and thousands of pages long. But what's given to a person that's considering participating in a trial are the information brochures and pamphlets that describe the trial, how long it will be, who is eligible to be in the trial, who is not eligible, how the people conducting the trial will protect the safety of the person participating. So, for example, if it's a trial of a new way to treat an illness and you're testing either a brand new medication or you're testing a new way of delivering that medication, changing the dose, for example, there has to be specific regulations that protect and maintain the safety of the person participating. So, for example, if there's a reaction to the medication, there's part of the study that tells the individual what number you would call if you're having any of these symptoms or have any concerns about a potential reaction to what you're getting. Another important part of clinical trials is being able to make sure you remove the bias. That is, the effect that individuals can have on skewing the data as you inquired about. And some clinical trials, the larger ones, will do what's called blinding. That means that individuals will be assigned to either the new medicine or the accepted practice, what's considered the gold standard for the current time, but no one will know. It'll be masked who's in which group. And what that does is it prevents the the investigator, and it prevents the patient from being able to say that their reactions, their benefits, or their risks from the medication are because they know they're in the group with this medication versus that medication. So there's very sophisticated clinical trial design protections, and there's also regulations that will assure that the result from the trial can truly be believed and trusted before it's even considered being put into clinical practice.
Speaking of regulations, are there any regarding the advertisement of clinical trials? Because you see in the newspapers, wanted, people, blah, 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 blah.
Yeah. Any material promoting a clinical trial, whether it's on television, radio, newspaper ad, has to have gone through the Institutional Review Board, or the IRB, that group of individuals that are independent from the study that can assess before the study begins all of the design, all of the science, all of the promotion materials, the brochures, where it's going to be played, and whether or not those materials and the study are going to put too much discomfort or risk to the person participating. That's their job.
But you see this ad. How do you know that it's a legitimate study?
Yeah. Well, again, having the public understand what the types of trials are, having the public understand what they should ask someone if they're approached to be in a clinical trial is critically important. And one of the first things they can ask is they ask the person, what's the evidence? How did you come to design this clinical trial to even test this new way to prevent or a new way to treat an illness? Clinical trials happen in an orderly sequence. So often a new medication has been tested in a laboratory and it has shown effect in a laboratory setting, and so then it is developed for human testing. And so the hallmark of a clinical trial is it's a medical research study in humans. It's not the lab part, it's in humans. That's why it's clinical. And so there are different phases of clinical trials. After you find something promising in the laboratory and it's time for human testing, there's phase 1, which are usually small numbers of volunteers. Those are called dosing trials, where the dose for a certain medication is established in that trial. That's phase 1. Phase 2 is effect trials. That is the new medicine in a treatment trial you're testing having the effect that you want? Is it slowing the cancer growth? Is it eliminating the cancer growth? Is it eliminating cancer recurrence? And that's a slightly larger number of individuals volunteer. Then the larger studies are phase 3, where if it's a treatment trial, you can compare a brand new treatment to what is the gold standard now. And the brand new treatment could either truly be a brand new treatment or it could be a different dose. You're testing it at a higher dose. And in order to remove the bias so no one knows which group the patient's in, but they have the ability at any time if the patient gets in trouble to unblind it or to reveal which group that person's in that got ill or had a reaction. Again, that's called the blinding. That is, the patient and the doctor won't know which group the person's in. And those are thousands of people participate or volunteer in those studies. And people that participate in research are volunteers. They can leave a study at any time with no penalty at all. And we want to be sure that the public understands that. So phase 3 can often take several years or a decade before they're finished.
Okay, I've decided to participate in a clinical trial involving knees, knee medication. What questions should I ask you?
Okay, the first is to ask, what evidence do you have that led to this being even tested in people? That's the first thing. They should be able to respond and tell you that we did studies in the laboratory and it looks like it's very promising. Next, you should ask, has your study been reviewed by an IRB or Institutional Review Board? And if the person says yes, can you share with me the IRB letter? They should be able to do that. If they don't share it or they say it has not been reviewed, you run in the opposite direction. You do not participate with that person. Then,
so does that mean probably it's a fake study?
It means that it's not being held to what's called the currently acceptable scientific and clinical research practices of today. So it could be for a number of reasons, but that's something you don't want to participate in if there has not been the ethical protections which an institutional review board, that independent body, is charged to protect people that participate in research.
But how am I going to know these questions before I go? Clearly, I haven't watched our broadcast. Is there written material out there, and how do you access it?
Yeah. For the community that we've spent years educating about the benefits of clinical trials, there's literature available with these questions from my office, the Office of Policy and Planning, at 410-706-1742. There are legitimate websites. For example, if someone's interested in federally sponsored clinical trials, at clinicaltrials.gov, that would has studies listed by zip code, by disease, that you could search to see if there's a study in your area for the particular disease, such as the knee medication, and they're all held to that standard of scientific design and ethical protections. The Cancer Institute at cancer.gov and the American Cancer Society at americancancersociety.org also have clinical trial parts of their website with correct information, and other voluntary agencies or health organizations that are legitimate would also have that.
What medical procedures do you go through before the testing starts? Do you get a physical?
It depends on the type of trial. So, for example, if you're in a clinical trial for a new way to prevent breast cancer, which we've had a couple of those in very important ones in recent years, but unfortunately African Americans and Latinas were underrepresented in those studies. So you would have a physical. This is laid out in that cookbook or protocol. You'd often have a physical. You'd have some baseline blood work. You'd be asked certain questions about your family history and your intake, what medicines you're taking, before it's even determined if you're eligible to participate. So there are very strict eligibility criteria, who can get into a trial, who could not. So, I mean, some of them are very common sense. If we're doing a prostate cancer clinical trial, only men with a prostate can be in that study. And if we're doing breast cancer, and it's specifically female breast cancer, then only females that have a certain type of breast cancer would be admitted.
You mentioned that the Hispanic community and African American community are underrepresented in these clinical trials.
Yes.
How do you account for that?
Well, if you examine, for example, the second leading cause of death, cancer, and only about 3 to 5% of cancer patients participate in clinical trials. And of that 3 to 5%, substantially under 1% is African American or Latina, or even rural patients are underrepresented. And we know nationally that there'll be over 1.5 million new cases of cancer and over 500,000 deaths in this year alone that are projected. But again, only 3 to 5% participate. Clinical trials have produced some of the most magnificent cures in cancer because of these people that volunteered to be in the study. And for example, Hodgkin's lymphoma can be cured by medicines that were developed in the clinical trial. We know that there are lots of barriers to research participation for African Americans and Latinas. These can be historical barriers because of concerns about exploitative research of the past. It could be that their doctor never discusses clinical trials. The leading national barrier to African Americans, Latinas, as well as the general public participating is the lack of their doctor discussing clinical trials with them. About 95% nationally, In research we've done in Maryland, it's also about 95%.
Well, the only way that I know about clinical trials happens to be when I see the ads in the newspapers.
Well, our approach to making sure that the communities that are not participating in medical research have greater access or opportunity to participate has to be at multiple levels. So we educate the public, but it's really important also to educate the community physicians and nurses and social workers so that they understand what trials are available in their community and what would be the manner of referring their patients. We know nationally, too, that the number of African Americans participating in cancer research is going down. We know in Maryland, in a study that we conducted, that the reduction of African Americans participating in National Cancer Institute-sponsored treatment trials is decreasing about 8.9% per year. And we don't know the exact reason, but we have some ideas. The other barriers are that often the clinical trials are in academic institutions. And so if you have someone who's very ill, who's in a clinical trial traveling from, say, the Eastern Shore across the bridge, it's very burdensome on them. And so we've tried also to place clinical trials in community settings in the state. There are top-notch. We have a clinical trial program in Easton that serves 5 counties on the Eastern Shore that we're partners with. And so we're addressing the infrastructure, the need to put them in the community, educating the physicians so they'll discuss trials with their patients, educating the public so that they have some understanding about how to access clinical trials on those websites and at our programs, for example. And then we address the historical barriers by teaching people scandals of the past and how the regulations will prevent those in the future.
Thank you. We're going to continue our discussion, but right now we have to take a quick break. Stay with us.
This is Mike. Mike is going to breakfast before he starts his day. What he doesn't realize is that Jim, his waiter, helped save his life. You see, Mike is being treated for heart disease. 10 years ago, Jim volunteered to participate in a clinical study researching a new treatment for heart disease. It was successful, and the new treatment was made available to everyone, including Mike. Like millions of other medical heroes, Jim's participation in clinical research was a gift to Mike and all people who might benefit from this new medication around the world. Just like Jim, medical heroes can be found in everyday places. To learn more about clinical research, visit CISCRIP, a nonprofit organization at medhero.org, or call 1-877-MED-HERO.
All right, Baltimore, listen up. It's getting real. A lot of people are dying around us at the hands of HIV/AIDS because they're not staying protected and they're not getting tested. And take it from me, personally, it's nothing wrong with being abstinent. It's not corny. You won't get teased for it. And trust me, at the end of the day, you're doing something better for yourself than you ever will. So don't get trapped by ignorance because you want to do something to make yourself feel good. Spread the word and not the disease, because AIDS is no joke.
Welcome back to For Your Health. Our guest is Dr. Claudia Baquet, and we've been discussing clinical trials. So why should I take part in a clinical trial?
Well, you have the opportunity in a clinical trial of being one of the first to receive the benefit of a new way to prevent, diagnose, or treat illnesses. That's a possibility. The other is that in reality that often many people may not see the direct benefit to themselves, but they'll see benefit to communities or to their loved ones as a new medication, as a new prevention method is developed. So there are people that volunteer because they are hopeful that this will help them with their illness. There are many more people that volunteer that want to help society or their communities or their future loved ones. And so those are some of the potential benefits. We know from a community perspective that not having adequate representation of diverse communities in medical research. Ask the question, are the medications or prevention methods that are developed of relevance for these populations when they weren't participating in the studies?
Well, for years, the heart studies only included men.
Yes, and then there were regulations from the National Institutes of Health, one specifically called the NIH Revitalization Act in 1993, and then it was renewed or amended in 2003 that said all federal sponsored research had to have women, minorities, and children. And if you didn't have those, you had to adequately explain why you didn't, or you would risk not having funding. Your studies would not be funded.
But based on what you've said, it's very difficult to get minority participation in some of these clinical studies.
And it's a very complex series of reasons. Okay, we've talked a little bit about people's fear and distrust of researchers. We've talked a little bit about the fact that to become eligible for a clinical trial, there's certain criteria. For communities such as the African American communities that often have multiple diseases such as hypertension or diabetes or other chronic lung disease, often having these diseases will be a criteria that says they can't be in the study. It will exclude them. They're called, you can't be in this because you have these disorders. And we're seeing that increasingly with the increase of interest in the general public, African Americans in particular, about participating in research, but then not being able to get in the study because they have these other multiple diseases that are one of the scientific criteria for not letting them admit it. So what's the solution to that? There are a number of researchers and agencies looking at better ways to statistically design these studies that will allow communities that have multiple diseases to be able to adequately participate.
You mentioned multiple diseases, which sort of segues into my next topic, and that's health disparities. What are health disparities?
Health disparities are diseases, conditions that occur at higher rates in certain communities compared to others. So, for example, in the African American community, there's a higher proportion of African Americans that survive less from certain types of cancer, that die more from certain types of cancer compared to the general population. You can also find examples of health disparities in Asians, in rural whites, in low-income patients, in Latinos. So it mainly states that there are differences in the rate of occurrence. Generally, it's higher occurrence in some communities compared to the other. Now, health disparities is a term that's largely used in the United States. A related term that's increasing in use in the United States but has been used outside of the United States for decades is health inequities or health inequalities. And that means that the diseases that occur, the conditions that occur, are not only unnecessary, they're unjust. And so health inequities, health inequalities have a social justice component, whereas health disparities is looking at someone gets this higher or survives less compared to the general population.
How do you account for some of these disparities? I mean, clearly there's lack of access to good medical care and health insurance.
Yes, there's a number of contributing factors. It's April, so it's Cancer Control Month. Next week is Minority Cancer Awareness Week, so I'll use cancer as an example in terms of the contributing factors. For cancer, there are risk behavior. So, for example, a person may smoke too much, they may drink alcohol, they may do it at the same time, which increases their risk for head and neck or oral cancers, the tobacco, the cigarette smoking for lung cancer. The individual may have a family history, such as their first-degree relatives, their mother, their grandmother, their daughter, had breast cancer, so they're at higher risk. The same we're learning in terms of prostate cancer in African American men, for example. We know that access is an issue. Communities without access have less cancer screening and prevention behaviors compared to communities that have really private insurance, for example. And in communities that may be uninsured or underinsured, may smoke a lot, may have poor diets because there's no access to fresh fruits and vegetables in their neighborhoods, and they have to take 3 buses to get to a grocery store and then bring all that food back on the bus. It's an interaction of all these factors.
So it's multi-level.
It's absolutely multi-level. Now, we also know that, unfortunately, with some certain forms of cancer, that there's an increasing body of literature that's being researched on treatment disparities. That is, if we know that this is the standard solid treatment for this cancer, it often is not offered to older populations, over 65, or African Americans at the rate that they should be. And this is a new field that's being studied, supported by NIH, called bias or discrimination in medical decision making in healthcare. So it's all of these factors put together, and the low representation of communities that have the highest cancer disparities in clinical trials. So now this is a lot of data, and it's overwhelming, and it can be very depressing. But our approach is always hopeful, because there are certain things we know about the importance of cancer screening, and Maryland has a number of programs that will provide screening, early detection, and if something's abnormal, a treatment for that. We're all going through in this country the Affordable Care Act, the implementation of health reform, and trying to make sure that everyone has access to health care. But you have to go further than just offering an insurance card. You have to make sure that available quality health care is available in people's neighborhoods.
But speaking of health insurance, there was a wonderful woman here in Baltimore, B. Gaddy, who everybody knew.
The irony. Yes.
Right, and she was always, she started this Thanksgiving dinner for the homeless that became so well known that it received national attention consistently.
Yes, she's wonderful.
She's a wonderful lady. I spoke with her for in another interview, and she had breast cancer.
Yes.
And I asked her, I said, B, why didn't you go to the doctor before now? And she said, I didn't have health insurance. And so that's another disparity. I mean, that's another issue here, is health insurance. People, you don't, and it's very tough to get and expensive.
Yes, and that's why I'm hopeful that the health insurance reform that is being implemented on the national level, and then in our state, a lot of that legislation and the insurance and purchasing cooperatives that went through our legislative session and got through, I'm hopeful that those kinds of barriers to quality health care are obtained. And the unfortunate thing is, for example, our individuals that are 65 and older have access through Medicare, and some people still aren't enrolled that are 65 and older in Medicare.
Why is that?
They're in rural communities. There's no campaign to get people to come and get what is by right. They're, federally supported health insurance. The other thing we've learned too is that there has been an increase in what I would consider biased views of seniors, and so a stereotype that, well, maybe they don't need aggressive cancer therapy because they're older and they're going to die anyway. And we've learned from studies that seniors actually do very well, sometimes better than younger patients, with cancer therapy. So there's a need to educate those providing health care to remove any biases they have against seniors. There's a need to educate seniors about what's their rights and insurance and get them enrolled in the programs that are their right to be enrolled in.
Do you think, in terms of education, in terms of providing access to health care, do you think having more minorities in the medical field, do you think that would have an impact?
Well, yes, I do. It's well established that physicians, for example, from minority backgrounds have a higher proportion of practicing in underserved communities and also accepting patients with limited insurance resources compared to the general population. But part of the health reform or health insurance reform is to provide availability, especially of primary care and prevention, an emphasis on prevention, finally, in this country. Providing those services broadly, that means we have to increase the physician workforce. Nationally, we have to increase the physician workforce and where people decide to practice in our state.
Because, I mean, that's difficult, and because a lot of doctors, frankly, they do not want to practice in rural communities. That's not where the money is.
It's not where the money is, and there's differential reimbursement rates. A physician treating a certain disease in a rural community in Maryland gets paid less
really?
than a physician in Baltimore City for a certain disease. And the other problem is that we have so much medical debt by the time we get out of medical school. Our medical students have between $180,000 and $200,000 in debt. And selecting primary care, which starts off at a lower salary, is not going to help them get rid of their debt. So often, having that debt influences where people will decide to practice and what specialty. They'll take specialties or subspecialties that are not primary care because they'll get more money and can have a better life and pay off their debt for their education.
I'm sorry, go ahead.
In Maryland, we have a program that's called Loan Assistance Repayment Program.
I was just going to ask about that.
This year, I've worked with members of the General Assembly on this program for physicians, and everyone knows that we need to do more debt forgiveness in order to get people to go to underserved regions in our state, and that's a national issue too. But this year, until the end of April, there's 6 additional slots available for physicians that will agree to practice in underserved parts of the state, and they'll have $50,000 of their debt forgiven or wiped out. There's other programs that I've worked with individuals across the country, because you have to have a senior mentor, that are funded by NIH that will also forgive. It'll wipe off $35,000 a year for 6 years of your debt. That's incredible.
Wow.
And they'll pay the taxes to the IRS for it.
Really?
That's a loan repayment program that NIH is fantastic.
Are a lot of people taking advantage of it?
Thousands and thousands.
I was going to say that's a great deal.
Yes. And so that would be a person that wanted to go into clinical research or health disparities research could do that. For Maryland, it's those that would practice in those underserved parts of the state that have been certified as underserved. They could get the up to $50,000 wiped out of their debt.
Not bad. Thank you. We're going to take a break, but when we come back, we're going to have our studio audience asking questions. Stay with us.
I'm Ian. I'm 6. Hey, I have diabetes. I was 100 days before I got diabetes. It's not that good. Diabetes is weird. Do you have diabetes? Yeah. My name's Kim. I got diabetes. In my life, there will be a cure. There will be a cure. We need a cure. How can you help?
Some parents are afraid to let their children play.
I start coughing and stuff. I have asthma.
Asthma isn't curable.
My chest be hurt.
But with the right medication, asthma symptoms are preventable.
Asthma never slows me down.
It can be controlled.
You can get asthma under control and give your child the ability to
play hard
and breathe easy. For more information, visit playhardbreatheeasy.com.
Welcome back to our program. We've been discussing health disparities and clinical trials with Dr. Baquet from the University of Maryland School of Medicine. We're now going to go to our audience for their questions. Could I have your name, please?
Hello, my name is Elizabeth Wake, and I'm an office assistant here. And I am a diabetic with, multiple things. And my main concern is, what are these clinical trials? I feel like they're trying to manage things and not eradicate diseases. And there's been a lot of reversing heart disease and reversing diabetes, but I feel like the pharmaceutical companies and all of these other type companies do not want to have many millions of people reversed because they, would lose the income. Is it clinical trials? Are they trying to eradicate or manage at this point?
That's an interesting question because I think a lot of people have that idea that, why can't they just cure it? It seems to me that the clinical trials are always for a new medicine.
That's an important question. So there are different types of clinical trials. There are treatment trials, so that would be a new way to treat an illness. There are prevention trials, a new way to prevent it from ever happening. Sometimes the goals of the treatment trial are to control the illness. Sometimes they are to cure the illness. So it really depends on the type of trial. Typically, the treatment trials are not necessarily for eradication, whereas the prevention trials, often their goal of the trial is to eradicate by not having the disease occur in the first place. And so it really depends on the type of trial. If you're interested with your medical history in participating in trials, and you're looking for potential study or medical study that's looking at eradicating the diseases that affect your health, then I always tell people there are a number of resources available with correct quality information on the web, such as the clinicaltrials.gov, or speak to anyone in my office, to me, about what might be available to help you navigate through what's available on the internet.
So in other words, there are resources that will tell you what type of clinical trial is underway, whether it's for treatment or...
It'll have the details. If you say, you can type in what disease you're interested in for you or a loved one. You put your zip code, it'll tell you who in that area is doing the trial or who is in a 100-mile radius doing the trial. Sometimes there aren't clinical trials. Most of the time there aren't clinical trials for everything. And the mission of our educational programs is not to let people think that everyone in the universe should be in a clinical trial. It should be to increase your willingness to consider it if you're informed about what the potential risk and benefits are that would affect a disease that's happening in your life or in your family member's life.
Let's go to another question. Sir, your name, please.
Tamarad Aklog, and my question is, in terms of patient rights, what rights does a patient have if they go to a physician or a general practitioner and they go in for a particular diagnosis and they seem to be pushed onto a particular drug? What is it that they have the right to ask?
Yeah, they have the right to be comfortable with what's being discussed with them. If they should exercise their right for true understanding of what the potential benefits and risks of the new medication will be, and to not agree to accept that new prescription until you're comfortable that you understand what the potential risks and benefits are, as well as, importantly, the cost of a new medication, which often can be very prohibitive. So the patient has that right to demand that they truly understand that they're actually part of their treatment process and understand the changes in therapy that are being proposed by their clinician or healthcare professional.
Unfortunately, though, so many people are afraid to question their doctor.
Absolutely, yes, they are. And we're trying with our community educational programs like MiniMed to remove that mystery and stigma that's often associated not just with research participation but with health, helping people become more literate about their health. And we feel that it's working because people are empowered by the new information and knowledge, and they're encouraged to ask questions of their healthcare professional, especially in this time where there's a heavy emphasis on cutting healthcare costs. I've seen that you have healthcare professionals, physicians, nurse practitioners, being much more responsive to what their patients are inquiring in terms of being part of the treatment process and the decision-making process.
Okay, my second question is in regards to the health disparity aspect of how physicians actually approach treatment towards patients.
Yes.
How are physicians that are being trained in the medical schools themselves, how are they being trained to treat patients of different ethnicities in different ways, sort of directed treatment?
Yes, excellent question. Fortunately, with the advent of the term health disparities and national attention on that topic, the medical school organization, American Medical Colleges, has developed a competency program for all medical schools to teach their medical students and their faculty what's called cultural competence in the delivery of health care. Now, cultural competence means that you would be able to treat your patient and take into consideration their culture and their influences on their health care, their ability to take medications, whether or not they're seeing non-traditional healthcare professionals.
Which is not that unusual.
Absolutely, such as other types, herbalists, healers. And so there is a move to have a medical workforce that's much more responsive to cultures and is attuned to delivering culturally competent care. This is fairly new. I would say that, again, an educated patient, an educated consumer, and their family is the best way to assure that you're getting the quality care. The numbers aren't out yet. We don't know, we haven't been able to show yet that delivery of culturally competent care produces the best health outcomes, although that's being studied right now. But that was a very good question, especially with the diversity of our nation. There needs to be an attention to cultural influences that affect how you deliver care. We know some cultures, for example, won't look in the eye of the physician.
No, they will not.
And a person who's not culturally competent physician will say that that patient is hiding something, they're sneaky. Whereas that culture, whether it's Korean or certain American Indian tribes, they don't look people in the eye. It's not a demonstration of disrespect. It's a cultural influence.
We have another question.
Hi, my name is Ava, and I'd like to ask, what happens if a person in a clinical trial presents with negative side effects to the medication that he's given?
That's a very, very good question. As I mentioned before, clinical trials are heavily regulated in order to assure safety of the participants who are in the trial. At the beginning of being enrolled in a clinical trial, the procedures for contacting the place that's doing the study, your study nurse is often who you're given the direct line to in a pager, is explained to you at the beginning of the study should you feel some adverse or negative effects of whatever group that you're in, whatever medication that you're taking. So if someone has an adverse reaction, the study will investigate it immediately and aggressively. If it turns out that it's not study related, that person may be sent for treatment for that and will remain in the trial. If it turns out it is study related, they're often taken out of the trial. If it's a serious adverse effect and numbers of people are experiencing this, often trials will be stopped. Clinical trials will be stopped if it's determined that the agents are not safe. They'll also be stopped if there's been an incredibly positive result, so they need to stop the trial and make sure everyone has the same medication and same benefit.
We have another question.
Hi, I'm Tom Summers. The medical research field asks us to put a lot of faith in their integrity and their ethics. And it seems like the linchpin of that structure is the IRB. How do people end up being placed on the IRB, and what steps do you take to ensure their independence and their ethical behavior?
Yeah. There are rigorous regulations that guide the formation, the membership, and the activities of an Institutional Review Board, or IRB. These are laid out in federal statute. There are guidelines for what type of people should be on the IRB. There should be, of course, because these are research studies, scientists with expertise in the different types of diseases, study design from biostatistics to the actual design of new medications to specific content areas like cancer or heart disease or diabetes. Importantly, there should be community volunteers, individuals who are not researchers that are from the community where the IRB is located have to be part of the IRB. And we're very fortunate to have members that have graduated from our bioethics mini med school program that currently serve as the community members on one of our IRBs. There are other members of mini med graduation classes that are being trained now for membership. It's a completely voluntary role. It meets a certain number of times per month. It looks at every single detail of a study and decides whether or not there's acceptable risk to the person participating, or it should never even be studied. And then periodically the IRB, for those of us who are researchers, may show up unannounced to look at your records to make sure you're protecting the confidentiality of those patients' medical records. They're locked in a file cabinet, and you're adhering to that cookbook or protocol that you said you would adhere to. Very strict, very rigorous, but enhances patient risk and safety and discomfort, lowers discomfort.
I just need to clarify one point. There are community members on this board as well?
Yes.
So-called lay people?
Correct. Yes, and they review the same studies that the scientific experts review. Now, it's fantastic that we're very fortunate that community members from our mini-med program felt compelled enough to volunteer. It is an incredible amount of work, combing through hundreds of thousands of pages of studies to make sure that all the regulations are adhered to. But they felt, this couple in particular, the stewards felt compelled after participating in our research literacy programs to make that contribution and to volunteer. And so they serve on one of our IRBs.
Is there any connection between health disparities and clinical trials?
Yes. We feel that the low participation rates in clinical trials by certain communities that have very high health disparities contributes to those disparities. Part of the lack of participation at adequate rates, say for example African Americans or rural patients, is that they're not being afforded the benefits of research advances at the same rate as the general population. We've mentioned before that if these populations are underrepresented in research of new medications, for example, for diabetes and high blood pressure or hypertension, are we certain that those medications will be effective in those patients when that group was not represented in the clinical study? And we saw this in some of the breast cancer prevention trials where there was low participation of Latinas and African Americans, and the trials were for what's called hormone responsive breast cancers, which Latinas and African Americans get less than their white counterparts, and so that seems to be contributing to their lower survival rate. So yes, health disparities is related to clinical trials. The low participation rate appears to be one factor contributing to health disparities.
Are there any programs out there then to address health disparities?
There are many programs in our state there are also some national programs available to people in the state of Maryland. For example, we have a Bioethics and Health Disparity Research Center at University of Maryland School of Medicine, which I direct, which works on cancer disparities, heart disease disparities, clinical trial disparities, and fostering public trust in research.
When you say you work on cancer disparities, what does that mean?
Some of the studies that we looked at, for example, in Baltimore City, there's a high breast cancer death rate in women. And one would assume that women were not being screened in Baltimore City. Our studies show that women are being screened in Baltimore City, but they're not coming back for the follow-up of abnormals. And so then the program is put in place to have people close the loop. It's the continuum of care: screening, early detection, and prompt treatment. Then we were told in some of the studies we've done with community groups that it's lack of health insurance, and it's a copay. And we say, well, you know, Medicare has covered these preventive services and screenings since 1998, and then again in 2000. And then reality checks in, and seniors say, but I can't afford the copay, so I'm not getting that prevention test. And so, you know, at that time where there were copays, then we had to backtrack and try to find resources for seniors to be able to effectively use that insurance benefit. So those are some of the studies that we've conducted. We've done studies of human papillomavirus that is related to causing cervical cancer and the new vaccine, and found that many in the faith community were opposed to the vaccine because they thought it would be related to encouraging sexual activity, which it is not. So there had to be a lot of education based on those studies and surveys, a lot of education on here's what the real science says. Here's a chance to prevent a disease from ever occurring in girls, and now the vaccine's available to boys.
We'll be right back after this break. Stay with us.
Hi, Mom. Hi, sweetie.
How's it going, buddy?
I'm bored. I think I'll ride my bike.
It may never be this easy to help your kids find balance, but you have more power than you know. The We Can Parents Handbook and website can help you maximize that power. You'll learn how to help kids choose healthier foods and how to make it fun for them to get active. Who can help kids maintain a healthy weight?
We can.
Visit the We Can website for a free Parents Handbook plus tips, tools, and resources. A message from the U.S. Department of Health and Human Services.
You know, I never knew how serious this AIDS thing was until it hit close to home. My brother used to be a straight-up player, and I used to want to be just like him. So I found out he was HIV positive. I mean, that thing changed my whole perspective on life completely. And it let me know you gotta resist in order to exist. So get tested and know your status. Spread the word, not the disease, because AIDS is no joke.
Welcome back to For Your Health. And before we say goodbye, do you have any final comments, Dr. Baquet?
Yes, I do. Although health disparities are very serious and prominent, it appears that they're not well understood across communities. And so we encourage people to learn as much as they can about not only their individual health, but the health of their communities by seeking out information from our program, which is Mini Med School program, seeking information. The state of Maryland has a hot off the press new program that will be implemented by the Lieutenant Governor to set up health enterprise zones to remove health disparity barriers that are in communities where people live. So that's a new resource.
What are health enterprise zones?
Health enterprise zones are a concept proposed and now signed into law, proposed by the Lieutenant Governor, to invest in the infrastructure and the tax base in communities that traditionally have high health disparities. So that would be certain communities in the state of Maryland, such as Baltimore City. Certain rural communities would also benefit. The regulations, this is hot off the press, it was just signed into law the day after the session adjourned, and now the regulations are being developed to allow people to apply as communities for designation as a health enterprise zone.
And once they get that designation, what happens then?
It will provide tax relief. It will provide incentives for physicians and other healthcare professionals practicing in those areas. It'll provide incentives for more of a focus on primary care and on the continuum of care, so that you're not just dealing with a person that's reporting just to an emergency room as a usual source of care. You're promoting community wellness. So it's a very, very progressive piece of legislation, and there are very high hopes. In the meantime, while those regulations are being developed, there are any number of federal agencies that have websites that will come also send their scientists to churches to educate people on health disparities and what are some of the solutions. One of the solutions is to learn as much as you can about the potential role clinical trial may play in improving health. And then ask your healthcare professional about clinical trials, or would they recommend that, a clinical trial. At the same time, we ask local healthcare professionals or community practicing healthcare professionals to take advantage of the free programs that we offer them through continuing medical education, to tell them what trials are available and what patients would be eligible to participate. So I think with the participation at multiple levels, the community, the healthcare professionals, the policymakers, that we can tackle health disparities. It can be an overwhelming situation to hear all these terrible statistics, but there are some hopeful things. For example, we know this month is Cancer Control Month, and so there's early detection, prompt treatment can lead to cure for a number of cancers, and any number of programs and resources available to the public.
Thank you so much, Dr. Baquet, for joining us today. And I would like to thank our studio audience, and of course, all of you for watching. Be sure to join us again on the next For Your Health. I'm your host, Camilla Carr.